ambient AI, and the findings from that and how it's shaped our operational processes at Great Ormond Street, and hopefully some of the learnings that we gathered during this evaluation of ambient AI will be helpful for you. So I'm sure you're all aware of ambient AI and the way it works. And I know there's a couple of demos later today on some different tools. So we recently led a pilot of ambient voice technology in a range of NHS settings across London, with some funding from various partners and NHS England to try and gather as much information and data from a variety of sites to see how the tool would work in separate and different situations across a whole range of demographics in London. So we really wanted to make sure that during our evaluation, we were gathering information and evaluating the admin burden for clinicians using this tool, and to see if it could help improve the patient and staff experience, which I'll come to later on our findings. So the tool we used during our pilot project was Tortus, and I think Dom's on the call as well. He's going to give you a demo later of Tortus itself. So Tortus, like ambient voice technology tools, can listen to the clinical conversation and then use generative AI to summarize and draft a clinic note following the end of the consultation. And obviously the aim of this is just to reduce as much burden from the clinicians in typing notes or writing notes or dictating notes after the consultation, so they can really focus on the patient during their appointment and give them as much time as they need to talk them through their issues. And one of the reasons we thought this was a particularly useful tool at Great Ormond Street is we obviously have quite a lot of sensitive conversations, and in so many of these occasions the clinician would hear something sensitive and then automatically start typing or writing notes and breaking that contact with the patient, which we didn't think was the best way of carrying out the appointments, but we know that's been happening for a long time. So we really wanted to make sure if this tool could help to stop that and to have the full attention of the clinician during the appointment. So we went on a variety of stages to test out ambient voice technology at Great Ormond Street. And we went for a very research-based approach so that we could gather as much data and evaluation and share this across sites. So we didn't just want this to be a Gough-specific evaluation. We really wanted to make sure that any learnings we gathered from this pilot project could be shared with other sites. Of course, this went through various levels of NHS governance, so we had to make sure we were very compliant, and Tortus were great in helping us to get all the documents ready for that. Particularly as sort of 2 years ago, this was a relatively new technology, and there wasn't much understanding within the trust and across the NHS as a whole on how these tools can work and how they could be safely integrated into a patient appointment. So we went for a very phased approach to make sure we're being as safe and compliant as possible. So the first phase we went on was just to build a working prototype for some of our clinicians at Great Ormond Street to review and make sure that the information that was being gathered and the output from the AVT tool, so Tortus in this example, was sufficient for the note to be put onto our electronic health record system, which at Gough we use Epic. So we worked very closely with Tortus to make sure we could build that prototype before we actually started deploying it in clinical situations. We then went on to phase 2, which was a very interesting and engaging period where we were at Tortus and using the tool, but with simulated patients. So we had some actors coming in and playing either the patient or the parent or carer in our example, because we mainly see pediatric patients at Great Ormond Street, and really seeing how it would deal with dummy clinical situations and how the clinicians could effectively save time by not typing notes. So for both of these, we carried out a baseline, so evaluating what the clinicians were currently doing without using any AVT tool, And then afterwards, using the tool, then generating some data on how much time they were saving, during the whole appointment, but also the amount of time it would take them to write notes, and also the contact that they had with the patient during this example. So we found some really interesting data from that, which helped us to move on to phase 3, which was 200 patients in a real clinical situation. So again, 100 of these, so just half, were baseline. So real patients coming in and clinicians not having access to a tool. And then we looked at comparing this to another 100 appointments using the same clinicians, but different patients using the tool, and comparing the findings between both of those studies. Again, the findings for this were incredibly positive, and both clinicians and patients really enjoyed having the tool in their appointments, and it really helped us to push on to trying to get some funding to look at the big study, which we call phase 4, which lasted for just over a year. So we really wanted to make sure that the tool we were testing and evaluating could work in a variety of settings, not just at a specialist pediatric hospital like Great Ormond Street, but across a whole range of different clinical settings. So we worked at an adult outpatient hospital in South London, Kingston Hospital. And we were there for about 2 to 3 months looking at a whole range of different clinical specialties and a whole range of clinicians who took part. We also did do some evaluation at Great Ormond Street, partly due to timelines of trying to get all these sites in order, and we found a bit of time, so we thought we may as well do an evaluation at Great Ormond Street as well. We also were at UCLH Hospital, which is thankfully just down the road from Great Ormond Street, so quite easy to get to. We also worked in a GP clinic in Northwest London for a couple of months, and we also looked at working with the London Ambulance Service and the North London Mental Health Partnership. So really trying to make sure that this tool could work across a whole range of different settings and could be used with any EHR. So Gough and UCLH did use Epic, but all the other sites we worked at used different electronic health record systems, and the tool worked equally as well in all of those settings. We also had a really good study at a accident and emergency hospital, so that was St George's in London. So that was working primarily with consultants in the A&E department, and making sure that, again, that tool could be used in a very fast-paced, high-pressure situation where clinicians are often rushing around and running from room to room. So we aimed, when we got the funding from NHS England and the HIN, to look at evaluating 5,000 patient encounters. So again, that was sort of 2,500 using no tool, which is called baseline, and another 2,500 using Tortus. Somehow we managed to absolutely surpass that and get to 17,500 encounters, which was absolutely amazing effort from all the team involved. So in all of these encounters, what we had is for most of them anyway, we had a physical observer in the room who was timing what the clinician was doing, what they were spending the time on, how they were focusing their attention on the patient, on the computer, on taking notes. And also to carry out surveys with each patient who'd come to the clinic on the day, and also surveys with the clinicians taking part. And I think it was around 120, 130 clinicians who were involved in that study. There was another sort of 40, 50 who were involved across A&E, but they were primarily using Tortus for the majority of their appointments. And you can see in the map the sort of roughly dotted map of everywhere we trotted across London, trying to look at all these different sites and trying to make sure that the tool works in as many diverse environments as possible. But we really wanted to make sure that the technology was independent of the digital maturity of each site. So all of these sites had very varying levels of digital maturity, which was quite challenging for our team to try and fit in and see how the tool could be integrated in those settings. But we did find that it could work, independent of the digital maturity of each site. So some of the sites we went to, we were still using paper notes and typing notes. Some sites were dictating after the patient had left the room, and some sites were the clinicians were typing during the actual appointment itself. And like I mentioned, there was a variety of EHR systems we used this for. So Epic at Great Ormond Street and UCLH, but we also looked at Cerner and another EHR system that the London Ambulance Service used as well. So just to get on to some of the findings that we gathered during this study. So I've picked out some of the ones we've highlighted in the report, and I've got some links at the end for the actual full report for those who haven't stumbled across it yet. It's a very lengthy 160-page document, which took a bit of time from everyone involved to type it up, but there's some really interesting findings in there for anyone who'd like a bit more information. So I'll just go through some of the ones I've picked out here, just to give a bit more of a definition on what we've defined them as. So we found a 23.5% increase in direct care. So our definition of direct care was how much time the patient was actually getting full attention from the clinician. So how much time was the clinician just looking at the patient, not typing on the computer, not writing any notes, not being distracted by pigeons flying outside, anything that falls under that bracket. So we found that by comparing the tool to the baseline study, there was a 23.5% increase in direct care, which was really positive for us to see, and one of the main highlights of the study, because it did really feel that connection between the clinician and the patient was being maintained, and that the patient was really getting the service that they wanted from the clinician. We found a 8.5% reduction in total time of appointments. So this is very varied across all sites. Obviously, we worked from GP sites, which usually have a lot shorter appointments, sort of 5-10 minutes, but stretching up to, I think our longest one was 2 hours at one of the outpatient sites we looked at as well. So there's a whole range of data going into that, but across the board, we found an 8.15% reduction in total time. So again, that was time from when the patient entered the room to when they left the room. So by using the tool, it actually sped up the consultation, because the clinician might not have been distracted taking notes during the appointment, and they could just focus solely on having a conversation with the patient. One of the most unexpected results was in the A&E site we were at. So we found an increase of 13.43% of patients seen per shift in the emergency department at St George's. So this was clinicians in the same amount of time seeing 13.43% more patients. And some of the interviews and surveys we did with the clinicians following that study were absolutely staggering, because they were happy seeing more patients in the same amount of time. They felt that when they finished their shift, they could go to the pub, they could go home, they could spend time with their family, and really just almost switch off and not need to then spend hours typing notes after the shift has ended. So really trying and reduce the clinician burnout that we know a lot of clinicians across the country are feeling with the demands for documentation. And yeah, that's highlighted in the sort of 51% decrease in time to actually complete the consultation, the documentation for the consultation. So there is still reviewing of the notes taking place, and we advised all clinicians when the AVT tool had produced a note for them, they still need to review it. And sometimes it could be very complex situations, and we really wanted to make sure that the output coming from Tortus in this instance was accurate, but still a massive reduction in time to complete their documentation and sign it off. That had increased benefits sort of down the line. So once a patient's been seen in A&E, they might need to go to another site, or they might need to go to another department. Having that documentation up and ready already in the electronic health record system they were using really helped to break that backlog of patients waiting to be seen and waiting for their documentation to come through. Working in the London Ambulance Service, so we saw an increase of 15% of patients assessed in the clinical hub. So this was, for anyone who's ever called A&E, when a patient calls A&E, they sort of get triaged into a queue, and some of the team of the London Ambulance Service will then call those patients and then make sure they've got a detailed, accurate history of their medical condition so that they could safely triage them and safely, if needed, push them up in the queue for an actual ambulance to come and visit them. So just by using the tool and having that in the background and then having the notes generated automatically really helped to help with that backlog. We also did a number of surveys, like I mentioned, with clinicians following the consultations they carried out using Tortus. So we found a significant reduction in their total cognitive load score. 35% reduction in clinicians feeling overwhelmed by note taking, which was expected to see a reduction of some sort, but a massive reduction was really positive to see. And again, there is the documentation still to review and sign off, but just by having that almost ready output at the end of appointment and just being able to review it quickly with a pair of fresh eyes and then sign it off really helped them to feel less overwhelmed, particularly at the end of a day when they might have not taken any notes and suddenly they have to write notes for 10 patients and then create letters. So it really helped to help clinicians in that instance. We carried out, like I said, surveys with patients following their appointments. So we found a really highly favorable score of using the tool. And to be honest, I was sitting in quite a few of these appointments myself, and for most of the time, patients didn't really know that the tool was being used, which was almost one of the biggest highlights. I thought that the tool was just there. The clinician was using for themselves, but they didn't notice any tool was flashing their eyes or the clinician was distracted by anything. So those were really interesting to see for the observers who were in the clinics. I've just put some word clouds on the right of some of the individual feedback we got from some of those surveys with clinicians. And the one on the top is from baseline, so when they weren't using a tool, how they were finding taking notes during appointments, and underneath is using the tool. So a complete contrast in the words coming out. And we know that a lot of clinicians across the country are feeling that same, that they're just very challenged with documentation and finding it completely draining on their balance of actually seeing patients and giving them the treatment. So found it really efficient and time saving afterwards just by having that tool and being able to move things along and not being sitting on notes for many weeks. Just so moving on from that, obviously there was a lot of feedback coming from that, and we really wanted to make sure that if there was any AVT tool being deployed at Great Ormond Street, we really wanted to make sure it followed these 3 rules we've put on the left. So making sure that it does no harm to the patient. But ultimately, we really wanted to make sure that the clinician was always in the loop. So the clinician is always in control of the notes being generated. It's not being automatically sent to the EHR system they're using. They always need to review it and make sure that was being reviewed and the note was accurate based on the consultation that was carried out. And by having that generated as soon as the appointment's finished, it really meant that they could have that memory to check it and approve it. That then helped us to develop our AI strategy, which was released, I think, a month or 2 ago. So building on all the evaluation we've had from this tool and building on a lot of other tools we've been developing at Drive and Great Ormond Street, really making sure that going forwards, any AI tool, an AVT tool in this instance, is safe and it's being properly tested and evaluated to make sure it does what we want for both patients and for clinicians, and making sure it follows all our guidelines, which, as everyone who in NHS knows, there's a whole load of them. We also produced some recommendations for the safe adoption of ambient AI to NHS England following our evaluation. Now, a lot of these are probably quite well known, but we know that there's quite a lot of tools out there which don't always follow these guidelines. So we do want to make sure that any other sites who are going live, any AVT tool, do follow these guidelines and making sure that the technology they're using is safe and is compliant with regulations. So I can share any of these slides with you afterwards, so you can read them through in a bit more detail. So there's quite a lot coming out of the phase 4 evaluation, which is rightly so because it was 15 months. So there's a lot of information, data, and qualitative and quantitative feedback coming out of that. So we did publish a report to NHS England, like I mentioned, as they did fund the study, which contains all the information we've talked through today, but in a lot more detail, and also a playbook for any other sites on how to safely adopt an AI tool in their local system. So we really wanted to make sure it was independent of Great Ormond Street, and any site could go through this and make sure that for any technology, they were following the same procedures and they knew how to get these technologies across the board, because we're more than aware how frustrating and cumbersome sometimes it is to get through the multiple ladders of getting technology actually deployed. We also helped to develop what we call as test. So that was just to make sure that any technology that's being looked at is almost marked against this framework to make sure that it's compliant, it's safe, it's accurate, and it follows what the NHS believe is to be a good technology, to make sure that not just random ones are being picked, but it follows a very succinct style of is it compliant? Do they have the necessary regulations on the provider or supplier side? And we've also produced a couple of papers as well. So the main paper is the whole study as a whole of phase 4, and all the findings that came out of that. We also produce a separate paper, particularly focusing on A&E, due to the overwhelming success we had there and the findings coming out of that. So we also did some work with the York Health Economic Consortium, which found absolute massive savings for A&E sites across England if they did adopt this technology. So we were able to calculate how many additional patients would be able to be seen in A&Es every day, and also the increase in funding if a tool was used in A&E and successfully. So where we are now, we were actually recognised in the 10-year plan. For those of you who read the document, which is really rewarding for everyone at Drive and Great Ormond Street and Tortus to be included in that. Obviously, the main focus of that is getting from analog to digital. So we really wanted to make sure this tool fit into that plan, and we think it absolutely did. So it's really rewarding to see that coming through. As I've mentioned, we've done a number of academic publications and produced tests, which is all on the NHS website for those of you who are interested in looking through it. And we are now in the very exciting stage of operationally rolling out Tortus at Great Ormond Street. So we followed on from phase 4, which was tested majoritively in an outpatient setting. So we started rolling out Tortus in all outpatient areas at Gough beginning of October. So we're just almost 2 months of it in. We've currently trained about 145, 150 clinicians who are using it, and we've got really good feedback from them so far on how they're finding it, particularly with clinicians who we haven't engaged with in the past. So about 90% of the 145 are new clinicians who've never experienced any AVT tool, and they've been able to safely embed it into their ongoing practice. And that's across a whole range of clinical groups, so consultants, resident doctors, nurses, and AHPs, and it's working so far, because only 2 months in, but working really well across all those groups. And we do have aims over the next couple of months next year to then test it and deploy it in other areas like Great Ormond Streets. So potentially looking at MDTs, potentially looking at our child ambulance transport service, and whatever else we find along the way. So I will just stop sharing there. I'm happy to take any questions.
Fantastic, Nick. That was absolutely fascinating. I put a link to the report that you shared previously into the chat. And I know you said it was 160 pages long, but it is a really great report. It's absolutely fascinating. So while people are formulating their questions, I'll just kick off with a few, if that's okay. So one is at the start, you talked about the phasing and the importance of doing that. And I just wondered if you could say a few words about where that took colleagues, how important was that to kind of bring people with you on an AI journey and to build that confidence, and what did the kind of socialization and communication look like in terms of the adoption of the AVT?
Yeah, absolutely. So we're very lucky in Drive to have a number of clinical colleagues who are involved in our unit, and very heavily interested in AI, which helped to get those early phases through the door. But yeah, it was really important to get everyone involved in making sure that this tool wasn't just built for one or two people, but built for the community as a whole, built for the whole group of clinicians. So trying to get them all on board, trying to get their views on what works for them, what they do in current practice, how they would like a tool to be developed. Obviously, this was a new technology almost 2, 3 years ago. It's a bit more congested now, but there are a number of suggestions and modifications that we've been working with Tortus, and we've been very lucky to have them as a partner to try and develop this tool to make it to listen to clinicians' feedback on what was working and what wasn't working, and to try and develop a tool that can learn from that and try to take on those suggestions. And it's gone leaps and bounds with technology, and it's really interesting and important to see how we've gone from that very early days source to where we are now, which is a tool that can pretty much do whatever, what the clinicians want it to do. And so to have the personalization of templates for clinicians able to create their own personalized templates was something that was raised very early on in those early phases. Every clinician likes their note to look something different, and some clinicians like a 2 to 4 line note, and some like a 3 page note. So being able to have a tool that could be personalized for those clinicians and everyone else in the middle was really useful in trying to get it safely adopted and trying to get clinicians on board. Very key to have their engagement early on and making sure that if we did try this tool, that people would actually use it at the end of the day. And so far, we found that to be a really big success.
Fantastic, thanks. And you also talked about the variation in digital maturity, and some sites were still writing or using a dictaphone. Could you say a bit more about kind of what adaptations you needed to make to be able to enable Tortus to be used?
I would probably say none, actually, but that might be putting it a bit too lightly. I mean, so the tool we had was at that time it was an app, so it was downloadable onto a clinician's desktop. It's now moved more onto the web portal page, so anyone with any access to internet can access it. Obviously, we needed to make sure that each site followed their own governance procedures, so we would work with the sites and with Tortoise in this instance to make sure that they had all the regular documentation they need to get it signed off, to get a DPI, making sure that everyone in the trust from the top down was aware of this tool, aware of what was going on, and making sure it was safe for those sites. But yeah, it worked. It doesn't, for the earlier stages, we didn't have it integrated with an EHR, which made things a bit easier. We knew we weren't going to be at these sites for too long, and the integration piece would take too long to solve. So by having the tool separate to an EHR, which it can do perfectly fine, and then being able to copy the notes across, meant it could work in all of those settings. Particularly as we were looking at the London Ambulance Service, so we had ambulance crews on the ground using iPads. We had sites in A&E in St George's wearing microphones and walking around from computers and going to computers on wheels. So by having the tool that could work, and even independent of what actual hardware they were using, not the software, was really interesting to see, and it showed that it could be used in almost any setting. So yeah, that was really interesting to see.
Excellent. Right. I have more questions, but I will open to the floor. So, first question. I'm sorry, I can't see you now. I can see RKE Agbor.
Oh, it's Ron. Yeah,
Hi,
sorry,
Ron.
Laura. I need to change that. It comes up with my initial, which is no use to anyone. Thank you, Laura. And Nick, thank you for such an illuminating presentation. If I might be greedy, a couple of questions from me. Given the incredible insight that you've had over the last 12, 15 months on this, if you could summarize for us, what are the 2 or 3 things that you're most excited about? And also, for balance, the 2 or 3 things you are most concerned about in terms of AVT and its rollout?
Yeah, I think rolling it out was something we're very excited about. We love to test things at Great Ormond Street, and to actually see something go from the beginning to the end and actually then being delivered to clinicians and not having to evaluate anymore, because we know it has massive successes for both clinicians and patients. So just getting that out and about. What we're particularly, again, interested in is working with a whole range of clinical groups. So due to the study parameters for phase 4, we had to see a certain amount of patients in each clinic for each clinician, which meant that for some colleagues and some clinicians who only saw 1 or 2 patients per clinic, we weren't able to involve them in the study, just due to the amount of time we had at each site and actually having to have physical observers in the room. So now that we've tested it and we know it works, we can now roll it out to the clinician who might see 1 patient a week, they might see 10 patients a week. It works for all those different clinicians. And so we've been able to engage with almost any clinician who holds an outpatient appointment at Great Ormond Street. Particularly some of the ones we're most interested in, the psychology and physiotherapy, which we found to be quite challenging at earlier sites. But now we've been able to work really closely with those groups and making sure that, like I say, the personalization works for them. And so one of the benefits we've seen is how the tool is able to adapt and pick up prompts from what the clinician believes is important to them. So when we were doing the phase 4 study and working at the North London Mental Health Partnership, some of the clinicians on the ground wanted a completely different note to some of the other clinicians we've been working at. They wanted the note to pick up that the patient might be observant of their surroundings, they might be observant of what day of the week it is, which for some clinicians would be totally excluded. So to have the tool being able to differentiate between those and pick up bits that are relevant and really work for clinicians really helps us to look at that. And some of the feedback we've got so far from those groups has been really positive and exemplary, and yeah, really happy that it can work across all those groups. The challenges, I think, yeah, I'd like to see it work in a lot more settings, not just outpatients. So we really want to start testing it across almost any single patient clinician encounter. And that obviously is new for us, because we've primarily worked in outpatients. Great Ormond Street doesn't have an A&E department, so we're sort of now looking for other things which we haven't tested it out. And we're not going to do a whole full-scale evaluation for that, because we know the tool works. We just need to make sure that the tool can work in these different clinical situations. So again, it's going to require a bit more communication with clinicians to making sure what do they actually want. So for example, when we start looking at ward rounds, how are we going to be able to safely capture that information that maybe a group of clinicians is having with a patient in an open space? So a lot of the appointments we did were in confined rooms. If a patient or a clinician is sat in a bed, how can we make sure that the tool can still work, and how can we make sure that the technology will be able to pick up all that information? And thankfully, we did a lot of our information, like I said, in Great Ormond Street with children who were usually banging on the table, throwing things around, running around, sometimes multiple siblings in the room, multiple people. So we did find that it could work in a room of 10 people, which was a bit claustrophobic for us, but really, really interesting to see that it could almost shut out the noise from the background and really just focus on the discussion that the clinician was having with the patient. And so we think it would work in an equally positive way in a ward round, for example. But these are the things we just need to test out. Obviously, we're now integrated with Epic, which has been a massive change for us because it reduces the amount of clicks, it increases the safety of the note going directly from Tortus in this case to Epic. But we'd like to see different more integration with Epic, and I think at the moment a lot of these EHR providers are restricting access to external AVT suppliers. I know they're starting to release some of those, and I think the more they start releasing, the greater the impact the tool could have in reducing not just the note-taking administrative burden, but a lot of the other administrative burdens, such as placing orders, making referrals. So I believe some of those are coming out shortly, which we're really excited to start looking at. And I think based on conversations we've had with clinicians, I think they're getting a bit greedy, but now that's what they want more. I think the note part is taken, so now they just want to make sure that as much administrative burden from an appointment can be automated by using an AVT tool. And just having that one tool do the majority of it, I think is going to make a massive difference to clinicians.
Thanks, Nick. Victoria.
Hi, Nick. That was fascinating. Thank you so much. I'm from Leeds. I'm one of the digital clinical team there, and we've got our own pilot on the horizon. So this is very timely. I'm curious about how the patients reacted. Did you have any patients refuse to be recorded? How did you handle that?
Yeah, so I think we had, of those sort of 17,500, we had physical observers in the room for about 5,000 to 6,000, I believe, of those. And we took written consent for every time we were using the tool and for having an observer in the room. I think our consent rate was 99.9%. So yeah, clinicians were perfectly happy with us having an observer in the room and the technology. They were just get on with it, particularly if the clinician was advocating the use of the tool. We found that to be a really helpful learning process, that sometimes a stranger coming to you in a waiting room asking you to sign a consent form was a bit scary and not really sure who we are. But a lot of the times we found that when clinicians spoke to patients, they really trusted their clinician and therefore they trusted the tool. We did have a couple of occasions, obviously, where patients didn't consent to that. A couple of that was language barriers. So there might not have been a translator ready while we're there consenting them. Sometimes that took 20 minutes or 30 minutes before the appointment. So they were a bit confused. We did have a lot of information sheets as well. So it could have been a bit overwhelming for patients sitting in a room, particularly if they're stressed about appointments and someone comes over to them with a sheet of paper, they don't know what they're signing away. So that was maybe, 10, 20 times or 30 times we found that to be an issue. But the main issue actually was when we were at gynecology appointments and we had male observers in the room, and that was just a no, pretty much across the board. So pretty positive, I would say. Everyone was really happy about using the tool. Not many concerns. We did have a couple of eager patients who really wanted to find out more about the tool. So we really had to make sure that, myself and the other observers knew how the tool worked, where the information was going. I think a lot of patients are worried about where their data is being stored, and we need to make sure
we get that a lot in our patient groups. One of the biggest questions we get from our patient reference groups is, where's my data going and who's got it? And that is what they're bothered about, which I totally understand. Yeah.
Well, yeah, I'd be happy to share the sort of consent information and information sheets we produce and see if there's any information there which you might not have included in yours. So please feel free to reach out on that. But yeah, I think like I said early on, a lot of the patients didn't actually know the tool was being used, which I thought was really positive. A lot of these patients, there might have been there might have been a follow-up, they've seen it so many different sites. They just want to have their appointments and get on with it, really. And so to have a tool which was doing all the work that a clinician would usually do and not even noticeable to the patient, other than them, the clinician spending more time with them, was really beneficial. And yeah, I think across the board, patients were really happy with it. So many people, when we told them why we're actually using the tool, why we're testing it to try and reduce that admin burnout on clinicians, they're really eager and almost grabbed the pen out of my hand to sign the form. So, but yeah, happy to share any of our learnings with you.
Can I be cheeky and ask a second question? Have we got time?
If you got a quick one.
Sorry. Did you notice any difference between sort of seniority of clinician and how often they agreed or disagreed with what Tortus had sort of presented back to them? Or was there, is there any sort of are people more cynical, or did they just not agree? And could you tell a difference in sort of the more senior clinicians compared to the more junior ones who might be more accepting of the technology? Was there anything like that?
Not really. I mean, there were a couple of occasions, but I wouldn't say it was specific to a certain seniority. A lot of clinicians we worked with have been, taking notes for 30, 40 years and have gone on a journey of writing notes and,
This is
then
how I like my
dictating
notes.
them
Yeah.
and then, dictating. So they have gone on a journey, and particularly a lot of those ones don't like typing. They weren't brought up on typing. So to have they'd often spend 10 minutes just, deleting and doing their spelling for 5-10 minutes of the appointment. So we were actually really positively impressed by how they adopted the technology. Obviously, there were some, we've got some clinicians who are retiring shortly and say, no, I'm not going to bother. What's the point? Fair enough. But there were a lot of other young clinicians we worked with who were equally as engaged. I think some wanted to do more, like we all do, but it's a journey we have to go on, and we have to, realize the path we've been on that phase 1 journey where we had very little to where we are now, and now we have a fully functioning tool that clinicians can personalize. So yeah, I don't think there's been any reluctance from any clinical group, any specialty, or any demographic, and particularly the tool we've been using is really good at picking up on tones and dialects and languages, and we've used other dictation tools in the past, which it always gets it wrong for clinicians, and they feel quite excluded from those tools. So when we've been rolling this out operationally at Gough, clinicians have been really impressed by it getting what they're saying is right, and they feel, I would say, a bit more included and therefore getting more involved in the journey. Like with all this, the templates need to be personalized. So if you get someone on board early, they invest more of their time in making it work for them. And it is a bit of an investment to make sure the templates are set up to what they want it to be. But once that's done, it's done. So by getting them engaged and enthused about the product has really helped us. We haven't really encountered any particular issues so far.
Thank you.
We've got just 2 questions in the chat, which I'll just pick up. So one is from Paul. Do you know roughly what percentage of interactions became entirely digital through the do you know roughly what percentage of interactions were fully automated in the pilot?
So I'm not quite sure what you mean by fully automated.
Paul, do you want to jump on and expand on the question? In which case, while he's doing that, I'll just come to Libby's question, which was, how did you approach use for ED with poor Wi-Fi access?
Yeah, that was a bit of a challenge. So we found that the tool would actually work a lot better, particularly when we moved to the web browser version of the tool. So we started on the desktop app, and we moved to the web browser, which worked a lot better and actually worked a bit faster than our EHRs we're using, which usually sort of churn away for about 10 minutes while they're loading. So we didn't particularly find any Wi-Fi issues. I'm conscious that there's a lot of areas which have really poor signal. We generally, we didn't find it took too much away from the study. At least not that anything was raised to us. I think some clinicians are so used to poor internet and a lot of sites that they just almost accept it now, which is a real shame, but they didn't feel that this impacted using the tool in any way. What we did in the ED department is we would have lavalier mics attached to a clinician. So they would go into, let's say, a booth and speak to the patient and have the mic on them. And they would have a dongle by their computer, and the information would go from the microphone to the dongle and straight into Tortus. And we found that worked really well for clinicians. The feedback we got from the ED department was absolutely amazing and quite overwhelming, actually, the positive feedback we got, particularly some of those personal stories about people just being able to get on with their lives. But yeah, we are conscious that the internet across many sites and even Great Ormond Street it can be really poor at points. And even if, let's say, the internet drops, and I'm sure Dom can come into this a bit later, that the tool continues to listen. So we haven't found any too many encounters where they've lost a consultation because the internet's dropped out, because we know that could be a problem. What I think some clinicians at St George's did as well is that they use their phones, and that's something we're trialing at, looking at when we look at our other use cases across maybe ward rounds, is if people have hospital approved phones and having maybe their EHR on their phone, using that, so you could get maybe a cellular service or Wi-Fi and still being able to use the tool appropriately.
Excellent. So Paul's come back, it's got some microphone challenges, but the question is asking how much of the interaction now needs zero manual input from the clinician from a digital perspective?
So it depends. Once the template's set up, so as we're training clinicians at the moment, we sort of spend half an hour with them, and we show them how to use the tool. Like I said, lots of these have never used any AVT tool in their past, or any AI tool even. And we are able to properly train a clinician in half an hour. So that involves getting them used to the tool, how to use it, how to set up a couple of templates. But we really want to make sure we're empowering clinicians to make the change themselves. So we could easily do all the templates for them. I'd be very tired at the end of the week, but it's easy to do. But by giving clinicians the empowerment to make their own templates, they feel like the tool works better for them. So yeah, half an hour to an hour, and clinicians after that point generally don't need to do anything else. Obviously, they might want to create other templates after that if they want to the note to focus on different specialties or to be a bit more discreet. But yeah, after half an hour, they're good to go. During the appointment themselves, as long as they press the start button, which yeah, they're trained to do, they generally don't need to do anything else, and the tool will just listen in the background. Like I say, the findings we showed that the clinician can just look at the patient. They don't need to look at the screen. Once the patient's left, click a button, review the notes, and on to the next one. And that's why we're able to find a real reduction in A, the appointment time, and B, the amount of time spent on documentation, either during an appointment or afterwards.
Fantastic. Thank you so much. That's been absolutely fascinating. Assuming okay with you, we will share the slides and any of the other kind offers you made in terms of some of the consent forms. So yeah, a massive thank you, and really looking forward to seeing the continued learning from the work in inpatients, ward rounds and so on, as you described. And we have got Dom on later doing a demonstration of Tortus, so a huge thank you. I'm now going to invite my colleague Graham Walsh, who's our Medical Director at Health Innovation Yorkshire and Humber, who's going to chair a panel with 3 colleagues from across Yorkshire and Humber and North East North Cumbria, who are at the start of their AVT journey, along with a colleague from Wolverhampton, who is a little bit further ahead with adoptions. So, Graham, can I hand to you?
Yeah, and thanks, Laura, and hello everyone, and thanks for joining us. And we can probably call it now because I think Nick's done such a great job. So I can get the rest of the day off. But I mean, we'll appreciate that. You know, gosh, you've done a fantastic job in bringing in AVT, but not every trust will have the same experience, and every trust will face a different barrier. So, as Laura said, I'm Graham Walsh. I am the Medical Director here at Health Innovation Yorkshire and Humber. I am still a practicing clinician, so for me this is really exciting because I first came across AVT way back in Kansas. It's topical at the moment with Wicked, isn't it? But way back in Canvas back in 2018, and it was just seemed so exciting at the time, and it seemed like witchcraft, and it's great that we now potentially have access to this in the NHS. So one of my roles was a CCIO, and I think what we've got is a mixed bag of people that are on a different stage in their journey. So what I'm going to do is I'm going to ask everyone in turn to introduce themselves and kind of give us an idea of where you are in your AVT journey. And then what we'll do is we'll go into a discussion, and we'll kind of hopefully try and cover many of the questions that many of you will have in the audience about, adoption, getting past the IG and many other barriers that you may face. But what I want to do is keep this relatively casual. So any questions at any time, if you put your hand up or ask a question, we can answer it as we go along. And hopefully it will help kind of gauge some of the conversation that we have on the panel as well. So it's a great panel. And again, it's a very mixed level of experience. I'm just going to quickly go around you all and just ask for you to introduce yourself. So I'm going to start with Leon Lindsay. He's from South Tyneside and Sunderland, and it's his Foundation Trust. So Leon might not be there. Okay, Leon might be having well, let's move to Jamie. Jamie Mills is the Chief Innovation Lead at Barnsley Hospital.
Yeah, good morning, everybody. Yeah, so we're starting to look at AVT in numerous clinical settings. We're going to start probably with the emergency department and the SDEX because they're kind of next door to each other at our trust. But we're also looking at some outpatient clinics, particularly where admin is quite high. And then we'll probably move on to inpatients later. But for the rapid pilots that we're planning, it's going to be largely in urgent emergency care and some outpatient settings.
That's great. That's great. And then Taj Hassan, he's from Leeds Teaching Hospital Trust, and we've obviously just heard from one of your colleagues asking a question, but can you give us an idea of where you are and in the journey?
Yeah, thanks, Graham. So my name's Taj Hassan. I'm a consultant in emergency medicine here in Leeds, and so I chair our sort of research group, and I think we're probably very similar to our Barnsley colleagues. We're early in our journey. We're going through our governance processes. We did have a bid actually with and discussions with Tortus about a year ago. So I think we've been discussing it for a year, and we're grateful to NHS Region for giving us some seed funding so that we can explore this further. And I really loved Nick's presentation. He's done so much of the hard work for us, and it potentially looks incredibly exciting. So yeah, grateful to be given the opportunity today. Thank you.
It's great. And Manpreet, I think Manpreet Singh, he's a consultant dietitian from the Royal Wolverhampton Trust. I think they're certainly further along in their journey. So I don't know if Manpreet's on the call.
Yeah, thank you, Graham. Manpreet Singh, I'm one of the consultant anesthetists from Royal Wolverhampton Hospital, and I'm a perioperative medicine clinical lead as well. And on top, I've got a clinical safety officer hat as well. So we piloted Clear Notes, which is AVT, in our preoperative clinics since March this year. And based on the findings and key outcomes, so this will be scaled up across the trust in various other outpatient clinics as well.
Okay, that's great. So I don't know whether Leon has joined the call yet, or just have to accept that Leon's been called into something else. Hopefully Leon can join at some point. But anyway, so I think let's move on, because I appreciate we've got time, because obviously Nick just overrun everything and he's just taken over the show. So I think what one of the first kind of questions I have, because way back when I was a CCIO, probably the most difficult thing I ever did as a CCIO was try and introduce voice recognition. And I know that's slightly different, but actually getting clinicians to kind of speak in public into a machine, it then converted into into text, and then to go into the EPR notes, it seemed to be a very difficult thing to do, partly because there's many barriers, the workforce questions about clinicians being able to communicate with staff, speaking out loud, and other people listening. How have each of you as individual organisations approached why you're bringing AVT in? Is it because of making life more efficient, making clinical processes better? Is it a cost saving? Is it a workforce reduction? And I know it'll be slightly different in each trust, but I'd be really curious to see how you've kind of got that buy-in from the board to invest in this technology. So if I could probably turn to Jamie first.
Yeah, absolutely. It's a good question. I think we've had some challenges with our EPR, and that's kind of facilitated wanting us to use digital dictation. So we started on the journey, probably much like yourself, Graham, where we looked at giving clinicians, particularly ones in high administrative areas, so paediatrics is a good example of this, where the amount of documents that they have to create and need to create to provide excellent care is vast and takes a significant burden. Now, with digital dictation, it's great, but it's not really natural language. So you have this kind of, okay, full stop, next paragraph, and you're talking into it, but the time saving there is arbitrary in some cases, because you've done your clinic, you've moved away, and now you're essentially just, the only time you're saving is what you could type versus what you could speak. Whereas this is almost the evolution. So we've looked at this as a natural progression in trying to make, and our biggest motivator, and it is with quite a lot of our AI interventions, is how can we be more human in clinical practice? And this seems like a very natural way for us to get kind of, we've probably all heard this before, but move the keyboard away and just look at the patient and have that conversation, that human connection with the patient. and the administrative side, which is really, really important, that still exists, but it's no longer the feature of the consultation that kind of comes afterwards. So that's really been our motivation to try and introduce AVT within the organisation.
Yeah, and I think that makes a lot of sense because you're getting people on board. So I've noticed that Leon's now joined. So just before we move on around the questions, if Leon, if you want to introduce yourself.
Hello, can you hear me and see me?
Yeah.
Good. I could hear and see you before, but for some reason I didn't show in the list. So hi, I'm the Associate CTIO for AI for North East and North Cumbria ICB. I'm a member of the Department of Health and Social Care AI Advisory Group. I'm on the BS 30440 and ISO panels for AI. So I hope to support the rollout along with my colleague Mike Smith across the ICB of AI technologies. We've got a lot of engagement in primary care, thousands of users now, and we have a safety case which we've published on our GP TeamNet. We're engaging with trusts. Currently, trusts seem to want to buy the bundled AVT with their EMR. That seems to be the drift. There's no appetite for risk, but we can talk about that further later. And I think support for AVT and the points that were made before about what is essentially human-computer interaction, optimizing interactions and processes are really what we need to think about. It needs to be problem-led. AVT is technology-led, but it's certainly a tool in the box. We can use it properly to speed up and increase the quality of healthcare, and we have to have the ethical context. But I'm happy to talk about any aspect, technical, managerial, process, just fire away.
That's great, thank you. And I think, as you know, that Laura's put together a program that we'll probably dive deeper into some of that governance questions a little bit later on, but we may touch on it obviously on these talks. I think moving to Taj, I think Taj obviously from A&E background. How do you see, and when you bring in AVT, and I know we heard a little bit from Great Ormond Street earlier, but in that kind of noisy environment of A&E, is this, are you envisaging using this to produce the clinical documentation into the record in that busy environment, or is this something that you expect, clinicians would go away into a room and and have conversations in a quiet area with the patient, which quite often I suspect you can't have in A&E. And how have you kind of overcome that conversation with clinicians?
Well, thank you. So I think what we're really actually interested in is learning more from our colleagues at St. George's, because it sounds like they've managed to sort of engage and address some of those issues. I think our perspective, we certainly have experience of digital dictation. We use ePro, and but this is a sort of very paradigm shift, as they would say. I think the issue about the ED setting, I think our initial plan is to introduce it into what we call our ambulatory area, which is probably a cooler, calmer environment, as opposed to perhaps a noisier resus majors area. But if colleagues from George's have managed to do it, then it'd be fantastic to obviously get their experiences. I think the big advantage obviously is efficiency, and the data from Nick prove that in terms of the improvement of that aspect of the process, and then overall the number of patients seen. I think there is also an issue around improved clinical safety and clinical risk. So emergency medicine is by specialty the second highest in terms of litigation in the NHS, and part of that process is the quality of the documentation, where clinicians don't necessarily document everything, and there's a fantastic potential both to maximize the clinician-patient interaction directly, which improves matters, and secondly, the number of patients that are seen. So, and thirdly, that the complete sort of consultation is documented, so that aspects that might otherwise have been forgotten are within the documentation. So those are all potential things, and I think they're all things that we want to explore in our evaluation.
I mean, yeah, I think that's, and it's very useful to be on calls like this where you've got some of the experts there, and you'll hear from some of the suppliers later of how they've overcome those. And I think to Manpreet, you're further ahead on that journey, and anything digital, as we all kind of know, there's that really excitement at the beginning where you're kind of going live, and this is really great. How have you done that ongoing engagement and adoption? And is this something that you found clinicians have kind of just embraced and kind of run with? Is this a digital product that actually clinicians wanted, and actually one of the rare things that they don't feel it adds anything horrendous to their day and actually improves their working life?
Yeah, thank you, Graham. I think great question. Actually, so our journey with AVT started last year when we expressed the interest for NHS England pilot. Before we started the pilot, we started with a pre-op clinic. So we have got only 10, 11 consultants. So we engaged with the pre-op consultants before we started the pilot, showed them the demo, what will be the eventual benefits. I mean, obviously, they have got some concerns at that point with the data and AI. So I think to get the colleagues on board, I think to allay the anxieties of them. So I had a meeting with the data protection officer as well, along with pre-op consultants, shows them what their concerns are, and we looked. So we did a bit of survey with our pre-op consultant before we launched that. What's their concerns? What they think that AI would do in few years' time, and I think that's helped in getting them on board. And I think, and once we launched this project after a few months of IG paperwork and clinical safety documentation and testing, I think ongoing support is quite key to get the product adopted among the consultants. I mean, initially, 7 to 8 consultants started using straight away. Few, they have still got doubts. So then the supplier and myself, we did an ongoing support to those colleagues, and eventually all of 11 consultants are now using the software in our pre-op clinics. Yeah. So and I think it's an ongoing feedback from the users and giving the feedback to the supplier that helps in improving the prompts or templates. So I think it's an ongoing support is key as well.
Yeah, and I think that is to any digital adoption. I think that's really is the key, isn't it? Ongoing engagement support. I think the question for Leon, which I think is, you mentioned that there's an awful lot of users already in primary care, and I know this is a secondary care event, and I'm not going to say that all GPs go in and teach hospital consultants how to use it, although that is probably a logical step. Have you found, the people that are using it, what are the barriers that, or the questions that they initially started with around clinical safety, around documentation, and were those concerns that they originally had, were they kind of put to bed very quickly, or did you have to do a lot of work to allay those fears?
So this is an ongoing process. We have unknowns at every level. So it is not as simple, let's just sort out this safety case. I worked with Shankar and Dom Pimenta from Tortus before, did a lot of discussion simply about whether or not AVT is a medical device. Alec Price-Forbes, who I worked with, only recently sent a letter out to say that it was, and this was after 2 years of debate. This is not straightforward. There's still debate as to whether it's class 1 or class 2A, and I don't want to complicate the issue here. I think we should carry on. Make sure that the system you're using is registered on the MHRA PARD database. If it is not, it's not legal to use it. Suppliers sometimes don't realize this. They're not necessarily familiar with the DCB 0129, 0160 process and need help. We just have to accept that it's new. We have to work together to get around this. There's no intention to contravene regulations. We just want to make progress, do good for patients as safely as we possibly can. Your clinical safety officer won't know enough about this. No trust safety officer does. They haven't been on a course. There isn't a course. Recent NHS England courses about Copilot, for example, have generated lots of questions that haven't been answered. So my answer is I can't answer you, but I can say what is currently legal. Make sure you followed your DTAC, DPIA, DCB process, checked with MHRA, and followed an accepted safety case. We can share ours with you from North East and North Cumbria if you like. I'm happy to put that into the chat if you'd like me to. If that would help. I shared it with our colleagues in Leeds. We've had meetings, we're working together, and I had a chat with Manchester too. Secondary care trusts. So I think it's almost like it's all just going to be turned on as part of a deal with the supplier in some cases, and so possibly secondary care may supervene. I get calls from CCIOs asking for input and help, and we provide support. ICBs are no longer funded to do anything. It's down to the individuals. It's actually down to individual GP practices to take their clinical safety officer responsibility themselves. They're independent operators, and each trust is the same. So it's a heterogeneous environment, it's complex, and as I said, it's full of unknown unknowns. The walled gardens of the EMR vendors are being put up very quickly, and we have obstruction rather than cooperation as a potential, and you heard that alluded to earlier on when there was a talk about Tortus integration. So what's the way forward? I think we should just work together, have a forum where we can exchange ideas. Nationally, it's quite difficult to provide advice because even nationally, there is not a full understanding of what this is all about. I hope that helps. I think it caused too much trouble.
No, and I think it is. It's an ever-evolving thing, isn't it? And I think, as something new comes on, we have to, and actually we've got Rebecca on the call today, who's will be talking about some of those governance questions that you asked. I think I'm conscious we haven't got a lot of time, and actually what I wanted to do is to ask the question. The first thing I'm going to say to Taj is, oh my gosh, cut and paste in EPRs is always a worry. You end up cutting and pasting the same thing that hasn't changed throughout that process. To be very wary of that. It's something that we faced at Calderdale, and just be very careful of that functionality, because junior doctors tend to cut and paste the first entry that has changed, but that's another point. But I just wonder whether AVT has an opportunity to change the way that we document. We tend to document from paper to digital. It's what we've always done. But is AVT an opportunity for us to create new templates at the way we communicate with primary and secondary care? So we can be more functional, so we can kind of be more efficient in the way that we get messages across to GPs. I don't know if anybody has a view on this, because I'm conscious we haven't got a lot of time, but it seems the perfect thing, because that natural conversation will lead to kind of recommendations and notifications to GPs. So I mean, I've noticed Jamie's nodding his head, so I'm going to turn straight to Jamie and put him on the spot. Yeah, absolutely. So I'm going to be very quick with my answer. Yes, I think that the biggest opportunity here is being able to produce multiple letters for multiple audiences. So no longer would we have to send out a letter to the patient, which is just them being CC'd into the GP letter. We can create one in their own language, and not just the language that they would use, so the reading level that they'd be hitting, but also their native language as well. But the other thing, the other point, or the other side of the coin that I'm concerned about is with large language models in general, they generate a lot of words. And so when you produce in the nice structured format at the end, sometimes I think the problem I've got is that's quite a lot that it's producing, and it can produce reams and reams and reams. And I think that's something which, when you start to have to read through it all, you think, oh, the information could get lost. And the other thing is you're probably reducing the amount of structured data you're getting out of this, because the output is unstructured. So when we've got things like diabetes where they need to produce national data sets and submit them, we're really pushing them towards all their documentation being as structured as possible. And I think with AVT, there is a risk probably at the moment where it sits that we're producing just unstructured documentation that we're putting into the EPR. And that's my very quick view. I've probably got a more expanded view. Yeah, and I think that's true. But I think one of the beauties about this kind of emerging technology, most of the suppliers are very open to working with with clinicians and with teams to actually make a better product and a better And if we get it right now, it's going to be right forever. We're at the beginning of the journey, and now is our chance to steer it. So I'm conscious we kind of run out of time. I'm conscious we probably could have talked an awful lot. I've not touched on clinical risk, governance, workforce questions. So there's an awful lot of questions we could have touched on. But thank you all. Now I am going to, and most people on this call, I would hope, are very happy to be contacted with any questions or anything else, you know, after the meeting. And it'd be really good, you know, if you know, when Laura sets these up, if we can all act as a little community where questions can be asked and we can share some of that learning. So thank you for your time, guys, and hopefully, as I say, everyone hangs around for the rest of the meeting and there's, you know, get some of the questions answered, or I can ask some of those questions. So back to you, Laura.
Fantastic, thank you, and just thanks to everyone for joining. We're really looking forward to learning from you along the way. So thank you for giving up the time this morning. Leon and many of you kind of voiced some of the challenges that we might face in adopting AVT, and so this next section is really to showcase some of the support that's available to you. And before I turn to Niels and Rebecca, I did just want to do a quick poll. So please